Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Welcome to Doc Discussions. I'm Dr. Jason Edwards, and this is a podcast where I interview other physicians. I'm here with my good friend today, Dr. Ruth Decker. Ruth, how you doing?
I'm doing great, and thanks for having me, Dr. Edwards.
Thank you, Ruth. Now, for those of you who don't know, Dr. Decker is a thyroid surgeon. She's a general surgeon, but she specializes in thyroid and parathyroid surgeries. Is that accurate?
Yeah, exclusively thyroid and parathyroid.
Yeah. And you know, that's really important because, as we know, physicians who do a same surgery multiple times, or they do it more times a year, have better outcomes. I think specifically with thyroid cancer or thyroid surgeries, it's 25 or more a year are known to have better outcomes.
Yeah, that's correct. And because there's a lot of nuances, and over time, then you're prepared because you've seen it before, and you're just more comfortable because it's almost in your DNA.
Yeah, you bet. You bet. We'll get into the nuts and bolts of thyroid surgery. But first, where are you from, Ruth?
Originally, I'm from Sheboygan, Wisconsin.
Okay. And so is that in southern Wisconsin?
No. It's
Okay.
north of Milwaukee. It's kind of mid. It's north of Milwaukee, right on Lake Michigan.
Okay. Okay. So like south of Green Bay,
Right.
north of Milwaukee.
Correct.
Okay. Very good. I would assume it's a nice Midwestern city.
Yeah,
good
mostly
place
blue collar.
Yeah.
We're near the bigger industries, Kohler of Kohler.
Kohler, the tool?
Well, they have generators. They do bathtubs, toilets.
Okay.
So
Gotcha. Yeah.
that's a big employer.
Okay, got you. Most of the stuff in Home Depot is going to be Kohler-like products.
Yeah,
Maybe.
maybe.
No.
Yeah.
And so, and then where'd you go to school at?
Undergrad.
Yeah, sure.
I went to school at Northwestern.
Very good.
In Evanston, Illinois.
Sure.
And I also got an MBA there.
Okay.
I attended medical school at the University of Wisconsin in Madison, and then also completed a fellowship in thyroid surgery here at Barnes Hospital in St. Louis. And following my medical training, I joined the faculty at the University of Michigan in Ann Arbor in the Division of Endocrine Surgery. I also had a research lab where I investigated the genetics of an inherited form of medullary thyroid cancer. My work was funded by the NIH, the American Cancer Society, and the American College of Surgeons, from whom I received a National Faculty Award for my research. And then in 1996, I returned to St. Louis and came here to St. Luke's. And I got a law degree from Washington University.
Very good.
So I've been in the Midwest the whole time.
And so not a lot of physicians have law degrees. You're only the second one I've ever met. And so how do you feel like that's influenced your practice?
I think to me, it has reinforced the importance of being very consistent in how you describe things to patients.
Yeah.
So that when you actually operate, they have a feeling within that they have made the right decisions, that they've been given alternatives. And if you're consistent, and I tend to use my whiteboard very generously, I draw pictures, I put down statistics.
Yeah.
And most patients come away actually stating that for the first time, they understand exactly why they're having surgery. And so I feel very comfortable in that approach. I don't, and even at after surgery, at time of discharge, I stand at the bedside and I have very detailed written instructions for their postoperative care. However, I go through the instructions line by line myself. Yeah. So I don't delegate. I think it's important. And you have enough respect for patients that you give them the time they need to understand why you're doing surgery, which when you think of, I mean, it's a very invasive, correct? Yeah. They're in a very fragile situation. They're under anesthesia. It can be very scary. And so you want them to feel that you care for them as a person, as well as a patient.
Yeah, your whiteboard is legendary. Patients talk to me about your whiteboard, and a lot of people say Karl Rove stole it from you.
Oh,
and
no.
so I don't know if that's true or not. But I mean, that's the tricky thing. Thyroid surgery, I mean, as you know, but to the audience members, that is kind of a high real estate area in the neck. I mean, you've got
in a very small area.
Very small area. You got the airway, the carotid artery, the jugular, and the recurrent laryngeal nerve, which is a big deal for thyroid cancer. For those of you who don't know, it's a nerve that comes out of the neck down around the bronchus in the chest and then comes back up to innervate the vocal cords.
Correct.
And it's kind of on the back side of the thyroid gland.
Right.
And so when you resect the thyroid gland, if you're too aggressive, you can clip those nerves and then people have a loss of voice, right?
That's correct. And part of it, and I do in my description, give a percentage that the injury is about 1%, but about 8% of patients can have a transient problem, not because the nerve has been severed, okay, but because there might be a stretch injury, meaning the nerve is attached to the back of the thyroid. So when you rotate the gland, the nerve comes up with it.
Okay.
And then the sheath to the nerve, becomes inflamed. And that can cause a transient change in the voice. Of course, this is very disconcerting to patients.
Yeah.
And it does require reinforcement. This just takes time. This will heal on its own. We do give the patient a high dose of Decadron to try to decrease that swelling. So, this needs to be explained in detail because I rather than just, delegating to another and explaining the anatomy to patients. And some pick up on it and they ask more questions about it. And even though one can use nerve monitoring
during surgery,
it still does not prevent those stretch phenomenon, right? Because you've identified the nerve. The problem is not whether or not the nerve has been identified, but how much dissection has had to happen around the nerve, especially if you're doing lymph node dissections. You're doing this dance around the nerve because they tend to hug the nerve.
Yeah.
And so it's just a very fragile situation. So.
Yeah. And you and I share a lot of patients. I don't see the majority of your patients probably, but a fair amount of them that have a higher risk thyroid cancer we'll see postoperatively. And it's actually, I can't recall any patients who've had any long-term damage off the top of my head.
Right.
I mean,
usually
you do a great job.
Yeah, they do resolve. The other thing I want to point out is most patients are asymptomatic when they present.
You bet. Yeah.
So this is a very difficult situation. Plus, their thyroid levels are typically normal. And so you're coming to them and you're saying you need surgery, you have this biopsy, and they feel no different. I mean, it's rare that the patient actually has hoarseness or difficulty swallowing, where they can sense, yes, this has to happen.
Yeah.
Most of the time they felt perfectly fine, and here they're undergoing this surgery. So you have, again, it takes educating the patient of why this has to happen. And of course, as you know, it's all about probability.
Yeah.
Rarely do we have 100% certainty that, yes, this patient has cancer. Even though the diagnostics have improved and evolved to try to perfect the probabilities, still you might have a situation where the probabilities suggest that they need the surgery, but yet on the final analysis that we get from the pathologist, we find it's a benign event.
Yeah. Yeah. Life is probabilistic, right?
Absolutely.
Be wary of anybody who ever says always or never.
Yeah.
I mean, that's the way we should talk, especially with informed consent, is to say high probability or low probability and try to give that probability if we can.
Yeah. And to make that very clear, that we, and it may not be, in some cancers, it may not be a one and done. We may have to go back and dissect more lymph nodes, or for recurrent disease.
Yeah.
So the patient needs to understand that as well. And maybe it was not detected initially with the current sensitivities of the imaging studies, et cetera. So.
Yeah.
if they're prepared for that, is important.
If you know it's a possibility, it's easier to accept when it happens.
Yes.
So, talking about imaging, the rate of thyroid cancer has increased over time, and there's some ideas of why that is. What are your thoughts on that?
Well, it again, because many of the patients are asymptomatic, many of them come to me with, well, I had this life screening at work.
Okay.
Or I had a carotid study. Or I had a chest CT and it picked up this nodule.
Yeah.
That is the more common. Once in a while, depending again on the astuteness of the primary care, that they will actually feel a thyroid nodule and then go on to order an ultrasound.
Yeah.
And of course, ultrasound, I think, has been with us since the 1940s, but it has really been the mainstay, for diagnosing thyroid nodules. It continues to be.
Yeah. And ultrasound technology has obviously improved a fair amount too over that time.
Right.
Especially my wife's an OB-GYN and, the ultrasound of the fetuses are incredible these days.
Yeah.
And so that's helped. Yeah. So you're saying increased detection just from these scans, incidentally finding lesions is maybe one of the reasons that thyroid cancer is increasing.
And again, and if you talk about the legal implications of that, I think gone are the days where one can dismiss it.
Yeah.
Correct?
Yeah.
So the referrals either for the thyroid FNA or to an endocrinologist or to a surgeon to assume that. And then the follow-up. Let's say the initial biopsy was benign, but again, that is not 100% accurate.
Yeah.
And so there needs to be some follow-up. And that's the other thing to reinforce to patients, that even if the initial biopsy was okay, there needs to be follow-up. And even more pressing in these times where the treatment is actually less vigorous, I would say, than it used to be.
Yeah.
Correct? Okay, for small cancers. This puts a bigger burden on the physician for ensuring compliance.
Yeah.
Because let's say you have a 1 centimeter papillary. Many of those can now just be watched, and operative treatment is not really recommended.
Yeah.
But that patient has to commit to coming back and repeating the ultrasound, okay? And even in some countries now, it's even going to 2 centimeters.
But you have to have a responsible patient. I mean, if it's
exactly.
if we've all had patients who are have kind of social situations that don't lend themselves to showing up for treatments and things like that, or maybe it's a personality. And those people aren't a good candidate to watch or to de-escalate the intensity of the treatment. And we're seeing de-escalation of care, like with rectal cancer. Some patients will have a complete response to chemoradiation and not need surgery. But you have to follow very closely. It's more work on our end, but it saves the patient a surgery.
Right.
Yeah. No, I think that's, there's plenty of patients that you see a nodule on the thyroid on a scan and you're like, it's probably nothing, but you can't neglect it. And 5 years later, they come back with a gigantic mass on their neck. You're going to be held legally culpable for that.
And it's interesting because since, of course, now we have the TI-RADS scoring of these nodules. And so that is some protection or assurance. Again, you're dealing with probabilities, correct?
Yeah.
Not absolutes. Because patients may say, well, and some of those nodules are fairly large, but they're either cysts or they're TR2, the scoring. And then you have to explain the scoring to the patient because then they don't understand why this, it's small, why does this need to be biopsied, et cetera.
So the TI-RADS is kind of similar to the BI-RADS, which is used in breast. And that's when the radiologist gives an assessment of what's the likelihood of the lesion to be a cancer.
Right.
Right.
And the whole point is the feeling that thyroid cancers were being overtreated at a time when the incidence was increasing.
Yeah. And the cure rate for thyroid cancer is really high for most thyroid cancers.
Right. But the other thing is, what about the patient that said, well, I heard this is really a good cancer?
Yeah.
What is the answer to that?
So I mean, this is my take on it. The patient, so for a papillary thyroid cancer, the cure rate's really high. It's like 99%, right?
Right. But if they're treated.
If they're treated.
Yeah. Okay.
Now, psychologically, I try not to downplay any cancer to a patient because psychologically they hear cancer, it makes them examine their own mortality mentally and emotionally. They don't feel this, how they feel is not commensurate with the probability of cure.
Right.
They feel horrible when they have it. One of the weird things about thyroid is it's papillary thyroid cancers about the cancer with the highest probability of cure. Anaplastic thyroid cancer, which is a more aggressive, is the absolute worst cancer you can get. It has the fastest mortality rate. I think it's 6 months.
Yeah.
And so it's just weird. One gland can have the best and worst cancer with regard to cure rate.
Doc Discussions with Dr. Jason Edwards. Brought to you by St. Luke's, St. Louis.
And the anaplastic is the progenitor of that is papillary.
Yeah.
So I've had patients that had within the same gland, you would see this progression within the gland where they would start out with normal papillary and then it would a watershed area where it was dedifferentiating. And then there was an area of anaplastic.
And fortunately, that doesn't happen very often.
No. But usually when it's consumed with all anaplasia, then the mortality is usually though from recurrence of distant disease, not from treatment of the primary. Is my understanding.
Yeah, and the treatment of the primaries it's really difficult to do a complete thyroidectomy because the tissue goes down into the chest, as you know, and so it's hard to get it all. And then we use chemoradiation,
right?
And that's a horrendous treatment. But fortunately, we don't see a lot of those.
I think I've had a couple, and this might have been prior to your time here, where we did have survival of 12 months.
You know what? There's one patient who's cured of it.
Was it a woman?
No, it was not.
It was not. Okay.
But it's a difficult treatment, and that's rare.
Right.
I mean, that's super rare. But we,
I think it's interesting because that is the one cancer where you actually need to, within a week, have a complete plan between the surgeon, the radiation oncologist, the chemotherapy, the medical oncologist, and you have to come up, core biopsy, what are the tumor markers?
Yeah.
Very different from the other cancers because time is critical in that situation.
Yeah. Yeah. It's fortunately, we don't see those very often. And so and then can you talk to me about parathyroid disease? So that's, way out of my wheelhouse.
Yeah.
And so, but I know it has to do with calcium regulation and whatnot, but can you go into that a little bit for me?
It's interesting because I would say, if you talk about the evolution of a career, it seems like I'm seeing quite more parathyroid disease.
Is that right?
You're right. And it used to be, I would say, see 10 women for one male. But it seems to be more common now in the male population as well.
Huh.
And of course, the treatment for that, the mainstay is surgical, obviously. Yeah. And we've had some better resolution as far as imaging, the SPECT imaging, the parathyroid nuclear imaging that has it, and now the 4D CT scanning. A patient I did this morning, the sestamibi nuclear scan did not show an abnormality. The ultrasound did not show an abnormality, but the 4D CT did, and that's exactly where the adenoma rested. Parathyroid cancer is very, very rare.
Yeah.
Thank God.
Yeah. But parathyroid disease is different than parathyroid cancer, right?
Yeah. And of course, the implications there is the bone deterioration, risk of kidney stones. And again, some patients have soft findings. They don't have kidney stones. They don't have osteoporosis, but they're very tired.
Yeah.
We pursue operative resolution for those that desire it. Some patients don't.
Yeah.
And a part of that also depends on the primary care because years prior, patients would be referred for they waited until calcium was 12. or so. And now that's not true. A lot of the patients I see are in the upper limits of normal or actually within the range of 10 to 11.
And do you ever see any patients with mental issues?
Yeah, chronic fatigue, loss of focus.
Yeah.
They have, they can't seem to memory problems. Some people have depression.
Yeah.
And insomnia is common.
From medical school, I remember the moans, groans, and stones. It was psychological moans, groans from bone pain, and then kidney stones.
Yeah. And of course, in the dialysis patient, a recent woman that I did, she had terrible bone groans and pruritus generalized. And she didn't realize it was due to this calcium issue.
Yeah.
And she was instantly cured of that post-op.
Yeah.
She was so grateful.
Yeah,
I mean, it was a major,
long, right?
it was a major lifestyle. It's immediate. I mean, the bone can be immediate the next day. It's gone.
How wonderful.
Yeah. So those are the happy campers.
Yeah. And so we've talked about, the thyroid disease and thyroid cancer, the rate going up because of increased detection. What other things do people think are contributing to that?
Well, I think the more and more the literature is suggesting that because there's actually endocrine receptors, as you know, on the thyroid gland, including estrogen, et cetera, and that things environmentally that are hormonal disruptors are increasing the incidence and growth of thyroid nodules.
And this would be like chemicals and microplastics and stuff like that?
Right. And I have, like, for instance, it's not only that, it's increased weight, so obesity. Sure. Because it increases the inflammatory state of the body. The adipose tissue is actually considered now an organ in and of itself. Okay. And the disruptors from an increase, in that tissue may also be affecting not only thyroid, but prostate and breast, I believe. Yeah. And so that literature, because the thing is, as our population have an increase in obesity, you're finding an increase in thyroid cancers. And so the question is there some relationship? And what are the mediators of that? Yeah. Right?
Yeah, for sure. And I actually was involved in a study where we would harvest fat cells and then spin down stem cells out of mature adipose cells. And stem cells have a ton of hormones in them. And so, and so does adipose tissue. So you got all these hormones floating around sheerly because of the adipose tissue. And you don't know, is the thyroid cancer causing the obesity? Is the obesity causing thyroid cancer? Yeah. Probably the latter. But that's the tricky thing with science, is trying to figure out which way the arrow is pointing.
Which came first. But the other thing is, although the link between smoking and lung cancer is very solid.
Very solid.
Some of these others, I mean, as a surgeon, would you say, well, you need to lose weight, or that's not going to be the resolution of the problem that's before me.
No.
So that would be more general education, maybe at the primary care level. Yeah. And it probably will happen, as more information becomes available.
Yeah, we definitely think that the diet's contributing to colon cancer. I mean, that's a less fiber in the diet in general. Right. And then we know that more fat on the body increases estrogen levels, which can increase endometrial cancer, which we've known for a long time, and contribute to breast cancer too.
It's interesting too, because they say that once puberty appears is when the incidence of thyroid problems appears in women.
Okay.
And now you don't see that in men. You don't see that kind of, and then that increases until the postmenopausal stage.
Yeah, that makes sense. It is kind of 20 to 55, right? I mean, it's like somewhere in there where it's the high point for thyroid cancer, which kind of is consistent with the hypothesis that it's driven by hormones to some extent.
Right. Yeah. Right.
It's very interesting. Well, Ruth, I want to appreciate all the good care that you've given our mutual patients over the years. You are an absolute expert in thyroid and parathyroid surgery, and your results speak for themselves. Thanks so much for coming on the podcast.
You're welcome.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.